Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. Welcome you back as I highlight a paper of particular interest to you by interviewing two of the authors of an article from the April 2023 edition of the Journal of Rheumatology. This month I picked for more in-depth discussion a paper entitled Etanercept Withdrawal and Retreatment in Non-Radiographic Axial Spondyloarthritis, results of RE-EMBARK, an open label phase 4 study, and it's by Dr. Filip van den Bosch and colleagues. And today I am delighted to be speaking with Doctors Filip van den Bosch and Atul Deodhar, who will discuss the results of this paper on the outcome of etanercept withdrawal in non-radiographic axial spondyloarthritis. And I want to thank you both for taking the time to speak to me and to our listeners. So with that, we'll begin. Okay. And could you please briefly describe the reasons the study was performed?
Okay, so thank you for the interest in our article, and I can take that first question. I think we all know that the phenotype of axial spondyloarthritis has dramatically changed over the last decade. We're coming from a situation where we were mainly talking about ankylosing spondylitis, which would be kind of an end-stage situation in the spectrum of axial spondyloarthritis. And now we're trying to diagnose these patients earlier. Now, patients with axial spondyloarthritis typically have disease onset early in life. These are young patients in their 20s and their 30s. They are likely to start when their disease remains active despite non-steroidal anti-inflammatory drugs. They are likely to start biological disease-modifying agents such as tumor necrosis factor inhibitor therapy, and they will start this early on in life. Now, we know that the data that there are available on the outcome of treatment after you reached a certain good response, when you then stop the treatment, those data are very important to these young patients because they consider a lifelong treatment as a kind of a high burden. So if they can get information that they can start with a certain treatment and there is perhaps an opportunity to stop that treatment once they reach the response, that's highly informative. Now, specifically for etanercept, the drug we studied, clinical trial data still remain quite sparse regarding maintenance of remission or the probability of flare after you have reached a good outcome, but you have discontinued the treatment. And so the RE-EMBARK study, which we're talking about here, was done, in fact, as a post-approval commitment to the European Medicine Agency after they gave approval for etanercept treatment for non-radiographic axial spondyloarthritis. And the main goal was to assess the frequency of flares after etanercept withdrawal amongst those patients that when they got a lead in with etanercept treatment, when they reached inactive disease. And then if they were in inactive disease and they stopped treatment, the secondary point to look at was to assess the efficacy and the safety of an etanercept retreatment when they had actually flared. And what we also finally tried to look at in this study was through a post hoc analysis to see whether there could be baseline predictors that would tell us which type of patient potentially could maintain inactive disease even after stopping the treatment. And if that was not possible, if there would be predictors to say, well, if you flare, will you then gain again a new response? So that's basically the underlying idea of this whole trial.
Thank you. Atul, anything to add?
These are very important questions, as Filip was stating. This is a strategy trial, and we don't have too many strategy trials in this field of axial spondyloarthritis. And so these are questions patients ask us: will I be on this drug for the rest of my life? And then we generally say, well, we might be able to reduce the dose, we might be able to stop the drug, but probably our experience is if you completely stop the drug, you might flare. But then the question comes, okay, if you flare, then will you be again regain the inactive disease status? And that's a worry that we have, that are we then making a problem for ourselves. That patient is doing fine, and then we reduce the dose or stop the drug, and now the patient is flaring, and have we created this problem for ourselves? So all these questions are very important strategic questions in day-to-day thing, and these are questions which we tried to answer into this particular clinical trial.
Yeah, I agree. These are super important questions, and that's why I asked you to review it in depth for the audience. So along those lines, can you just let us know who was studied, what was the entry criteria, how many patients, and which countries were involved? Because obviously we're in Europe and North America.
Yeah, I can take this question. This was a multi-center, multinational study. This was a global study, 62 sites, 14 different countries, including the US, Australia, Taiwan, Colombia from Central America, and various countries in Europe. There were 210 patients. This was a study on non-radiographic axial spondyloarthritis. So these are, as Filip mentioned earlier, younger patients. So these patients were between the ages of 18 through 49, and they had to have the diagnosis of non-radiographic axial spondyloarthritis. They had to then fulfill the ASAS criteria, classification criteria for axial spondyloarthritis. But these were non-radiographic, so they should not be having definitive radiographic sacroiliitis according to the modified New York criteria. The X-rays were centrally read, X-rays of their sacroiliac joint. And the other important point is we wanted to enroll patients who had active disease. And so different things. I mean, they had to have active disease in the sense they had to have back pain more than 4. They had to have their BASDA score of more than 4. But in addition, they had to have active objective evidence of active inflammation. So either they had to have high C-reactive protein, or they had to have positive MRI on the sacroiliac joint, or both. So that was the kind of population that we studied in this study.
Thank you. Anything to add, Filip?
Well, yes, I think the only thing is that those are really the patients we should be looking at. I think the whole issue with non-radiographic disease, certainly in the United States and North America, has been, are we not including patients with a specific back pain instead of patients with a true inflammatory disease? And I think the inclusion criteria and the patients that were included in this trial tried to the best of what we know to include this specific group. So
yeah, I agree. So the people listening don't have the benefit of figure 3, which really described the 3 phases of the study. And could you just outline it, how the 3 phases were done, how many patients, et cetera, et cetera?
Okay, so the RE-EMBARK study comprised actually of 3 parts, as you already mentioned, and they are shown in the figure. Basically, period 1 was a 24 open label run-in periods where all patients that qualified according to the criteria mentioned by my colleague, that all these patients received open label standard etanercept treatment. That would mean 50 milligram subcutaneous injection every week. And then during that 24-week period, we try to see what percentage of these patients would get into a state of inactive disease, which was characterized by the ASDAS index, and the ASDAS cutoff of less than 1.3 signifies inactive disease. Now, once the patients reach that point of inactive disease at the end of the 24-week first period, they could enter the second period, which was actually the withdrawal period. In that phase, patients actively knew they were stopping treatment. So this was not a double-blind situation. Patients reached a good status, and as you would do in daily clinical practice, they stopped treatment if they were in a state of inactive disease, and then they were followed for about 40 weeks. If during that period of 40 weeks, a flare was detected, meaning that their ASDAS, their disease activity score, once again got higher, and therefore we used the ASDAS ESR, because the ESR gives you let's say the possibility to quickly look at it, and after an hour you know what the result is. So if we identified patients that flared, then they entered period 3. Period 3 was actually a retreatment with the same etanercept dose, 50 milligram once a week, and that was to see whether patients that lost their response actually regained their response. Now in period 1, if you want to know about the numbers, 209 of the 210 patients that were included in the study, they received at least 1 dose of etanercept. They got it on top of a stable and non-changed background non-steroidal anti-inflammatory drug treatment. Out of these 209 patients, at the end, 190 patients, so that is 57%, achieved the status of inactive disease at the end of period 1. And at that point, those patients, so those 190, were eligible to enter period 2. In that period, as I already mentioned, they stopped the treatment and then they were followed, but they continued on their background non-steroidal anti-inflammatory drugs. And then in period 3, we have 88 patients. So that's out of the 119 that entered the stop period. There were 88 patients who experienced a flare during that withdrawal. And of these 88, the vast majority, 87 to be exact, received retreatment with etanercept. They entered then period 3 in order to receive for another 12 weeks. And in that period, we checked whether they would regain their original response. So that's basically the outline of the 3 periods in this trial.
Anything you'd like to add?
Yeah, if I may just add, I mean, this is this trial reflects real life situation is the way I think about it. I mean, the first period that Filip was talking about is the way we treat patients. I mean, this is open label, the first period. You're treating somebody with etanercept, and the patient has done well after 3 months, after 12 weeks. And the patient says, well, I'm doing so well, can I now stop the drug? And then you withdraw the drug. And then you wait for a period of time and then see what happens. And if the patient flares, then you restart the drug. I mean, this is exactly how you and I would practice in daily medicine. You open label drug. If they're doing well, stop the drug. If they flare, restart the drug. And that's exactly, and then the only thing is here we are doing it in a little bit more very objective things being checked, whether you really are in remission. And then where you really in flare, and what is the definition of flare? And then do you regain the status of inactive disease? And then as Filip mentioned, then we are also going to see post hoc, what are the factors, which are the baseline factors, which actually predict who has this maintains, who gets this long maintenance of inactive disease status, and also who regain the inactive disease status. So I think this is a very real life situation type of trial, reflecting what happens in day-to-day.
Yeah, I agree. It's a very pragmatic, it's what we do. So it's very important. So that leads to the obvious question, what are the results?
Yeah, so the primary endpoint in this RE-EMBARK was the proportion of patients with inactive disease who flared within the 40 weeks of etanercept withdrawal. That's the primary endpoint. And so people do start flaring immediately after you withdraw, but then at 4 weeks, so a month after they withdrew, 22% of the patients, this is the period 2 we are talking about, when they have been inactive disease and now they are withdrawn. At 1 month, 22% of the patient flare. And by the end of 40 weeks, 67% of the patients were flaring. But then if you look at it another way, is what percentage of patients had at least one period of flare during their follow-up? Then you will find that about 75% of the patients flared at some time during this withdrawal period. But that means 25% of the patients maintained inactive disease for 40 weeks after completely discontinuing etanercept therapy, which is to me pretty exciting. That a quarter of the patients, I mean, that you have treated only for 12 weeks and they are in inactive disease and you are not giving them the drug. 40 weeks later, 9 months later, they're still in inactive disease status, which is very good. The other thing we found out was the median time to flare was 16 weeks, which is 4 months, which is also important, also of practical importance. Patients have to stop biologic therapy for surgery, for COVID, for infection, whatever. If you stop it for 4 months, 16 weeks, etanercept, then it appears that chances of flare are very less, because that's the median time to flare, which means those patients didn't flare in that particular time. The other thing, another important result, most of the patients, 62% of the patients who were retreated with etanercept after a flare re-achieved the inactive disease. Inactive disease is a very difficult, stringent endpoint. ASDAS of less than 1.3. I mean, I would have gone for ASDAS of less than 2.1. This is very stringent. But still, 62% do regain that status after retreatment, which is also very good. And the 50% of those who regained that inactive status did so within 5 weeks. So those are very interesting and practically important outcomes, results of this study. The safety results were not surprising. There were no unexpected safety signal. Most common treatment emergent adverse events, as usual, is upper respiratory tract infection, which is what we generally see. So there was no surprises there.
Filip, anything you'd like to add?
Yeah, just wanted to add what was already said, that because of this pragmatic design, it's very informative to our daily practice, because there have been other trials, and surely from a scientific point of view, you can say, well, shouldn't it have been a double-blind withdrawal? But then you introduce, because of the placebo withdrawal phase, you introduce that patients do not know it. They think they flare while actually they're still on the drug. And so this here tells you in real life, okay, you stop the drug, you do a flare, you start the drug, 5 weeks later, you're basically fine. And for example, Atul mentioned the COVID situation, infections. I could think of young female patients which are comprised in this non-radiographic stage of the disease. They want to become pregnant. They can sort of estimate now, well, do I want to continue such a drug, or I'm feeling really great? Should I maybe discontinue, see what happens? What are my chances? So I think this pragmatic design really is helpful.
Thank you. I agree. As we discussed before, there was a post hoc analysis done. And could you please then go over the results of the analysis of the predictors of inactive disease after etanercept withdrawal?
Okay, so what we did is we tried to figure out if there were certain patient characteristics at baseline that could tell us which type of patients would remain without a flare if you stop the treatment after you've reached a status of inactive disease. We did a univariable and a multivariable analysis. And in these studies, in the univariate analysis, what came out is that if you start with a patient who has quite a low CRP at the start, I remind you, that means the patient should have had a positive MRI, because that was the inclusion criteria. You had to have objective signs of inflammation. But if the patient had low CRP values, that was a predictor to say, well, you reach a good status, you stop the treatment, you can maintain it. The other one that came out, both of the univariate and the multivariate analysis, is kind of a complicated one, which is based on the objective signs of inflammation already discussed. And as mentioned, we have positive CRP, we have positive MRI. You have to have either of them or both to get into the trial. So basically, at the end of your inclusion, you are having a patient group that has either CRP positivity, MRI negativity, or it has MRI positivity and CRP negativity, or it is the double positive group where you have patients that have both MRI and also an elevated CRP at the start. And what came out of both analysis, uni and multivariate, is actually not having this double positive phenotype. So actually the absence of being in a state where you have both MRI and CRP that's positive, that's again a predictor. So this tells me that in patients where you've included them, they have pain, they have a positive MRI, but their CRP is not that elevated, or the other way around, they have an elevated CRP, but there is no clear-cut inflammation on the MRI. That's probably the patient group where you can think of stopping the treatments in a quite safe way when you reach inactive disease.
Thank you. Anything to add, Atul?
I think this was this is also of practical importance in that if I'm seeing a patient who already has significant inflammation at the start, then I'm going to tell the patient the chances are that your risk is going to be higher of flaring. And so I would really like to treat this for much longer than just about 12 weeks. Here, the study, the first period was only 12 weeks. So this also helps me in my, when I'm assessing and deciding about which patient I withdraw the treatment.
Yeah, I agree. I mean, it makes logical sense. And what struck me about this study, as we digress for a moment, it was only 12 weeks of treatment. I mean, it is amazingly short in somebody's lifetime and for us, and to come up with predictors, even, it was really interesting to me. So as we know, there are always some limitations. Do we do our best? And could you just please outline for the audience some of the important limitations of the study?
Okay, so strictly speaking, from a scientific point of view, the limitations, of course, there is an open label design. So the patients knew they were on treatment, so you might overestimate the treatment effect. And then the patients were stopping the treatment if they were doing fine. So also there was no control group. So there you might have a higher impact that patients say, well, I'm feeling a bit of back pain again. So this open label design without an absence of a control group is a limitation. On the other hand, I think we demonstrated it might be also a strength in order to apply this to daily practice, but that's how you look at it. We also have to say that in the end, given this 3-period design, you have patients that start, then you have to have patients that get into inactive disease, which is not so easy to get this stringent response. So there's a relatively small sample size in the withdrawal group, and certainly also then in the retreatment group. So that might be considered as a limitation. The other thing is that nowadays in the treatment and the management guidelines, we are told that probably we should not abruptly stop, but probably it's more cautious to sort of tapering the treatment, so kind of prolonging the interval of etanercept to an injection every 2 weeks instead of 1 week. That was not explored, so we don't know if that would have given us another result, more patients than the 25 patients that remain well. So dose reduction or prolonging the interval was not in this protocol. And then finally, yes, of course, it was already mentioned, but the analysis of the baseline characteristics that predict whether you would do well or not is a post hoc analysis, so it was not a pre-specified point. So that's, I think, the final kind of limitation that we have in this study.
Atul, anything to add?
Yeah, no, I think he summarized it quite well. I think it was a pragmatic study, and so there are these kind of things which come into that, especially lack of placebo group. That's the major one. But I think this was done it was meant to be a pragmatic study. So yes, you can say that that's a drawback, but then that was the intent of not having a placebo control anyway.
And I agree. I think, there's always limitations, but I think it answered the question it was meant to ask, being real life practice, which leads to what I have my final. So as people are sitting out there, what is the takeaway message for people listening for their patients who would have met the entry criteria and were on etanercept? So what is your take-home message for these people? And there are sure lots of patients out there like this.
Yeah, I would say there are many important takeaway messages, and they're all of practical importance, and we have covered them in this interview. But just to quickly go over one after the other, the primary endpoint in this study was what percentage of patients who have achieved inactive disease are going to flare after you stop. That is a common question patient asks us. And this study tells us that most of the patients who achieve inactive disease, but they stop, they would flare. However, I am a glass half full person, and I would say that a quarter of the patient who actually stopped the drug still did not experience flare for 40 weeks, despite stopping the drug. This to me is a very astounding and again, as you said, Earl, we had only treated this patient for 12 weeks. So just 12 weeks of treatment, early aggressive treatment with a TNF inhibitor, especially etanercept here, for 12 weeks, and then you withdraw the drug, and 25% of the patients still remain in inactive disease, a very stringent outcome 40 weeks later. This is take-home message number one. Number two is half the patients who achieved this inactive disease, they could maintain that inactive disease, low disease activity for up to 16 weeks. And that's another interesting point that we could use in daily practice in clinical situations, as Filip was mentioning, pregnancy or infections or surgery or whatever. So these data actually inform us about the shared decision-making that we do about treatment interruptions, restarting the drug, etc. And that brings my third point, actually, that if you restart the drug, most of the patients, 62%, are going to get back into that status of inactive disease. So we shouldn't really worry about stopping and restarting the drug. So those are some of the important takeaway messages of this study. And I do want to, before I close, I do want to disclose that the publication was supported by Pfizer. And this was funded by Pfizer, and the medical writing support was provided by David Center of this Engage Scientific Solution, and he also was funded by Pfizer. So I do want to give credence to where it belongs.
Filip, would you like to add anything to that?
I think this was brilliantly summarized. I think it was throughout the interview that we tried to emphasize where can it help us. And then the major message is, yes, indeed, a group of patients will flare. Probably, as Atul mentioned, you should not stop treatment if you have a really severe patient with lots of inflammatory burden at the start. But that's not all our patients. We do have these patients with milder disease phenotypes, but nevertheless, having the disease, having symptoms, having poor quality of life. And in these patients, this is a perspective that we can give them and that we can discuss, because in the end, it is a shared decision, as was already mentioned, where you have to say, well, these are your options, but now we are able to better inform them.
Thank you. Anything you'd like to add that maybe we missed? Don't feel obliged. I thought you did a great job.
Thank you. No, I think we covered everything. Thank you. Thank you all. Thanks for the opportunity.
So, and I want to thank both of you, Drs. Filip van der Bosch and Atul Deodhar, for taking the time to review the findings, which I think, as we've said, are very pragmatic, very useful findings in everyday care of this group of patients. And to our viewers and listeners, please read the whole manuscript entitled Etanercept Withdrawal and Retreatment in Non-Radiographic and Axial Spondyloarthritis Results of RE-EMBARK, an open label phase 4 study by Dr. Filip van der Bosch and colleagues, and it's now available for your reading at the journal's website at jroom.org, and of course will appear in the April print edition of the journal. So thank you for joining us, and hope you'll join again next week when I speak to an authors of an article of particular interest that was selected for the May 2023 edition. And we'd love to hear any comments or concerns you have. You can send on Twitter at jroom or by email to manuscripts@jroom.com. Thank you.